All right, welcome everybody this morning. Thank you for joining us today for the CVRN Rising Stars Seminar Series. Today we have two really awesome speakers who will present on both exercise and nutrition as the pillars of cardiometabolic health. I'd like to just start off by acknowledgement of country. We acknowledge and pay our respect to the traditional custodians of the lands and waters of New South Wales and all our Aboriginal elders past, present and emerging. We respectively acknowledge the traditional custodians of the land and the land that we are present on today, and their continuing cultural, spiritual customs and practices. All right, so for our August seminar, we're going to talk on exercise and nutrition. And so the two speakers that we have today, so the first speaker up will be Dr. Helen Parker. So Dr. Helen Parker is an accredited practicing dietitian from the University of Sydney. She is a very impressive lady who balances her research and teaching and motherhood at the moment. Helen will present her work on nutrition, and her topic is on, it's not always about weight loss, alternate approaches to nutrition for obesity and cardiometabolic risk reduction. So our first speaker today is Helen. So I'll invite Helen to come and share her slides.
All right. Well, thank you so much, Mon, for the introduction, and thank you to the Cardiovascular Research Network for the invitation to speak today. As Mon sort of alluded to, I'm very excited to be here today. It's been a rough couple of months with daycare and sicknesses and things, but now we have 15 minutes just to talk about nutrition and obesity and cardiovascular disease, and I'm very excited to be here. So I will preface this talk with a little brief comment on weight loss. So while weight loss, even of small amounts, is associated with significant metabolic improvements and improvements to several cardiovascular risk factors, weight loss and the maintenance of weight loss remains a significant challenge. So while some of my research is looking at techniques to assist individuals with weight reduction, it's also important to consider that weight loss is not always possible or necessarily the best course of action for an individual. And indeed, even when waiting to lose weight, it's good to have other targets to keep improving cardiometabolic risk factors in the meantime. And I'll talk just about one or two of these today. Okay, so I know I'm speaking to the already educated when I say that obesity is highly prevalent, and it'd be great if we could somehow treat it, because it is an independent and important risk factor for heart disease, among other things, since obesity affects some of those standard modifiable risk factors such as blood lipids and blood pressure, but also itself increases the risk of heart disease. And on the slide, you can see in dot point form some of those mechanisms by which obesity can increase cardiometabolic risk, such as impaired glucose metabolism, hypertension, dyslipidemia, systemic inflammation, and more. Now, a lot of my work focuses on overweight and obesity, and traditionally one defines overweight and obesity by body mass index, among other things. However, BMI defined obesity is just one factor that should be considered when examining risk relationships between body features or body components and cardiovascular disease risk. In fact, BMI can hide a lot of the truth. And by looking at BMI alone, one misses a lot of opportunities to improve cardiovascular risk. One of the features associated with obesity, and is indeed itself a risk factor for heart disease and cardiometabolic disease, is visceral fatness, or higher than recommended quantities of visceral adipose tissue sitting under the muscle belly of the torso, enveloping those internal organs. You can see obesity see visceral obesity by measuring someone's waist circumference and recording a high number. So we have some cutoffs that we typically use or typically talk about. Of course, they should be thought about in an ethnically specific manner, but generally 94 centimeters for males or above 94 centimeters and above 80 centimeters for females represents increased risk of chronic disease or lifestyle disease. But there's a whole other school of research on the TOFI individuals, thin on the outside, fat on the inside, where waist circumference might not be that high, but they host substantial or larger than expected amount of visceral adipose tissue anyway. And that's beyond what I'm going to talk about today. But anyway, I just thought it was good to mention those things. Visceral fat isn't like your standard metabolically relatively inactive subcutaneous fat sitting just under the skin, for example, on your hips and thighs. Visceral fat is its own endocrine organ and does a lot of things. So here you can see some of the pathways by which visceral adipose tissue contributes to increased cardiovascular disease risk. So lots of different pathways here. Some of you will also know that these intermediaries, such as fatty liver in the middle there, are also themselves independent predictors of cardiovascular disease, and the systemic inflammatory state is common to both cardiovascular disease and obesity. So the part of this figure I'm going to start with today with regards to nutritional input or nutritional effects on this particular thing is in the middle there. So the things impacting liver fat synthesis and accumulation. So here we go. NAFL, or non-alcoholic fatty liver, has been shown to be an independent predictor of cardiovascular disease, which is why I'm focusing on this particular thing today. When preparing this talk, I had so many things that I sort of want to talk about, but there's only 15 minutes, so we'll just keep it limited. The liver isn't meant to store fat, and fatty liver is defined when the liver has greater than 5.5% fat. So NAFL is present in up to 90% of adults with obesity, and it's making its mark among the younger age groups as well. It's not unheard of in lean individuals. However, the bulk of NAFL burden seems to fall among those with obesity. Some people indeed call NAFL the hepatic manifestation of the metabolic syndrome. So you can see the kind of sort of research field that this falls into. So metabolic syndrome, type 2 diabetes. One of the important things about NAFL is that it's now the most common chronic liver disease and the second most common reason for liver transplantation in developed countries. So that's pretty massive. And indeed, it can exist just as benign liver fatness or liver steatosis, but it can also progress through to fibrosis, cirrhosis, end-stage liver disease, and liver cancer. And a certain proportion will progress through each of those phases. In addition to it being a significant cause of liver-related morbidity and mortality, NAFL is actually an independent predictor of cardiovascular disease. And a 2016 meta-analysis found that patients with NAFL were at higher risk of fatal and non-fatal cardiovascular events than those without NAFL. So it's quite an important thing. The next thing is that treatment options are actually quite limited. They're limited to diet and exercise with the primary goal, so we say, of weight loss, although I suspect Angelo may shed some light on the benefits of exercise even without weight loss in his talk in a few minutes' time. And I'm going to start with a single nutrient approach to non-weight loss focused therapy for NAFLD. So this first alternative or novel approach to nutrition for cardiometabolic risk is dietary supplementation with omega-3 polyunsaturated fatty acids. So we'll talk about dietary patterns later and focusing on the whole diet later, but omega-3s are quite special, so hear me out. So why omega-3? There are a few reasons. So firstly, there's evidence that shows that patients with NAFLD and NASH, so non-alcoholic steatohepatitis, have lower intakes of omega-3 polyunsaturated fatty acids and lower body status of omega-3. So you might see this as a high dietary or a high red blood cell omega-6 to omega-3 ratio, or a low omega-3 index. Some people also talk about plasma omega-3. However, that's more highly influenced by your last meal. So the omega-3 index, or the red blood cell content of omega-3, provides a longer-term measure of body omega-3 status. So while I'm just a bit about the omega-3 index, while I'm going to talk about the omega-3 index in relation to NAFLD, the omega-3 index is actually based on the risk of cardiovascular disease that was given by a certain red blood cell membrane levels of omega-3. So omega-3 of less than 4% of fatty acids in the red blood cell membrane was associated with significantly higher cardiovascular risk, and above 8% was associated with lower risk of CVD. So, and given that we make next to no EPA and DHA from precursor fatty acids, we get the vast majority of these from our important fats from our diet. So low omega-3 intake and low omega-3 body status is an issue relevant to NAFLD and cardiovascular disease. So looking at some of the potential pathways by which omega-3 can reduce fatty liver, we see that there are several very plausible mechanisms by which sufficient omega-3 intake may reduce liver fat and cardiometabolic risk. So sort of tipping that balance in favor of fat oxidation rather than fat synthesis and accumulation in the liver, among other things. So how does it measure up in clinical trials? It would be very convenient if this easy, simple, readily available, no need to lose weight sort of therapy for fatty liver worked well. And while we would, of course, love for patients to lose weight too, this novel therapy is not necessarily about losing weight or making large-scale changes to diet quality, although that would be nice, of course. Omega-3 supplementation itself may be a way to reduce fatty liver and reduce cardiovascular disease risk. So the next bit of what I'm going to talk about is looking at what's out there in terms of studies examining the effect of omega-3 supplementation on liver fat. To cut a long story short, this is an updated version of the first ever systematic review on NAFLD and omega-3, which I did the first one back in 2012, and then we're updating at the moment. So these are the top line results. Okay, here we go. I'll just pop all these up on the screen. We had a variety of participant characteristics and study designs. Nothing like those massive clinical trials of medicines in cardiovascular disease, but a good start. So I'm just going to pop that up just so you can have a quick look. A couple of different populations: NAFLD, NASH, PCOS, overweight, You've got a variety of study designs. There are more and more randomized controlled trials these days. Some of the older ones are those non-randomized trials, and a variety of age groups, so from 30 odd to 60 odd years old. And I'll talk about the measurement of liver fat in a few minutes. So the duration of supplementation ranged from 8 weeks to 2 years, and the dose ranged from quite low to very high amounts. And some doses were just EPA alone or just DHA alone. So I guess just to keep that in mind. Some studies incorporated dietary changes as well, which muddies the water a little if one's wanting to see just the effects of omega-3. However, one could also argue that diet plus omega-3 is probably a more real life scenario than just supplementing with omega-3 alone. And the differences between studies did not end there. The dose forms of omega-3 and the control varied widely from your standard fish oil to highly purified EPA and or DHA, and through to omega-3 PUFA not further specified. Traditionally, those are the older studies that had the not further specified. We're getting a lot better at reporting the exact ingredients of the capsules these days, or the omega-3 supplementation these days. And so here are half of the results. As you can appreciate, the study quality ranged from okay to pretty good. But we've separated the results here into the way in which they assessed liver fat change. So this first slide of results is using MRI or MRS to quantify the amount of fat in the liver. So, you can see you've got like percentages, like point something percent. You can actually quantify that with MRS and MRI. So you can see there are some studies that favour omega-3 PUFA, but also some non-significant difference between the active and the control groups. And one of the key points in this particular slide is actually in the italics down the bottom, where the UK team led by Eleanor Scoletti found that it mattered how much DHA was enriched into your blood cells rather than whether you're on the active or the placebo supplement. So if you started with a certain level of DHA in your blood cells and it rose by at least 2%, those people are much more likely to see a reduction in liver fat than people who did not see quite so much DHA enrichment in their red blood cells. So I'll come back to that about sufficient change in omega-3 later on. And here are the results for ultrasound or biopsy. So where liver fattiness was assessed by either of those methods. So ultrasound asks the doctor to assess how bright the liver looks in the image. The brighter the liver, the more fat it has. Therefore, it doesn't have quite the level of detail that MRI and MRS have. But if you're seeing big changes in liver brightness, then you're seeing huge changes in liver fat. So these studies here where you're seeing, even half a level of steatosis change, that's actually quite a lot of change in steatosis or fattiness. I guess some of the keen viewers will also note that some of the older studies seem to show the difference between omega-3 and control groups, whereas some of the more recent studies don't tend to favour either arm. And I don't know if that's sort of common in other research fields, but I just find it interesting here. So I've tried to see if there's one feature that more commonly delivers benefit of omega-3, and the meta-analysis that we're planning to do, if possible, will be useful here. So first up, the dose form. You can see that fish oil seems to have favour like not significant differences between studies, whereas the other types, we seem to have a few more positive findings in terms of favouring omega-3 PUFA supplementation for liver fat reduction. In terms of the population studied, it's about 50-50. If you choose a population who already has non-alcoholic fatty liver, you may or may not get a benefit from omega-3 supplementation. Duration short versus long, it seems that the longer duration ones may have more benefit, although it also seems to be about 50-50 for the long duration ones as well. The dose per day, one would sort of expect that the higher the dose, the more benefit you're going to see, or the more, I guess, difference in liver fat you're going to see, but not necessarily the case. And then we're splitting that up between EPA and DHA as well. And again, it's about 50-50, although slightly less good for some of the higher EPA studies here. So it's a bit all over the place. And here's another really, I thought, quite a nice way of depicting how it all sort of panned out. What you can see is the little red dot for each study shows you the duration against the dose of omega-3. So you can see there's some quite low dose omega-3 studies here down the bottom where it's sort of 1 gram a day, up to a couple of grams a day of omega-3, up to some very high dose studies here where they were taking 50 mils of oil per day. And across the bottom, you've got duration. So some short-term studies, sort of 8 weeks here, up to 12 months on the sort of closer to the far right of the screen. And in the red text, you can see where there was no significant benefit of omega-3 PUFA, or there was no greater reduction in liver fat. And in the green text, there was a greater reduction in liver fat in the omega-3 PUFA group. So yeah, you can sort of see that perhaps some of these longer term ones, but again, in the previous slide, we didn't see that it was necessarily only the long-term ones that worked. And I've now overlaid that with the dose form of omega-3. So in blue, you have fish oil. I figured marine, water, blue. Red was ethyl esters, and the green is other. And if you may recall, there's quite a long list of other types of omega-3. So we have this issue where omega-3 can lead to liver fat reduction, but we're as yet unable to come to what dose or duration or dose form is required to achieve these benefits. And we also need to have further study to see if this results in a concomitant reduction in cardiometabolic risk. So if you do reduce liver fat, can you reduce cardiometabolic risk? The hypothesis is that one should reduce cardiovascular disease risk if they have a reduction in liver fat. However, we also know that sometimes things don't work out quite the way one thinks they should. The case in point being a paper I read recently about weight loss and how it didn't lead to all the benefits that were hypothesized, including cardiovascular disease risk reduction. So a bit of a summary on that bit, and then I'll spend a very short time on, like 1 minute or 2 minutes on the next little bit, and then I'll end. So this is one of the research threads I'm sort of pulling at. And if anyone has funding or wants to collaborate on this sort of thing, please let me know. So omega-3 appears to be effective, but also can be ineffective at reducing liver fat at low or high doses, short or long supplementation durations, and a variety of dose forms. And so this is where I'm hoping to get really into the nitty-gritty in the next couple of years, is that could it be affected by something else? So the baseline omega-3 status of that study by Scoletti, where they saw that if you had a high enough change in DHA in your red blood cells, you saw a benefit in liver fat. So perhaps those with low omega-3 status to start with might benefit most. Whether or not you absorb omega-3 supplements better or not as well, with or without a meal. Unsurprisingly, things like baseline liver fat level or amount of disease progression might be important, or it could be something else, which we haven't looked at yet. So very briefly, now that I've had my fun talking about my single nutrient approach to managing cardiometabolic risk, I'd like to give a very short, but more complete overview of the links between diet and cardiometabolic risk. So everyone thinks they know diet. If you eat too much of the bad foods, you gain weight, store more fat, and eventually you have perhaps obesity and maybe heart disease, right? Well, not quite. There are nuances in there that are missed by many people. So firstly, what are good and bad foods? Too much of any one thing can be a bad thing, and you don't need to gain or lose weight to see the impacts of diet on cardiovascular disease and other metabolic diseases. So for many years, nutrition scientists focused on single nutrients, as I've just shown, but things like cholesterol or fat and saturated fat, and then more recently sugar. But we eat food, not nutrients. And also we know that balance is the key, and this is where the study of dietary patterns comes in. So dietary patterns are that cumulative total of one's diet, the always, the sometimes, and the rarely eaten foods, all examined at a kind of a bird's eye kind of view. What's really great is that there's evidence to show that healthy dietary patterns of all different types are associated with lower incident cardiovascular disease. So think maybe Mediterranean diets or the healthy eating index. So that's one of the ways that we can measure dietary patterns. You can score a diet quality indice. There are a couple of different diet quality indices that we can use, or you can check how well it fits to a particular dietary pattern. So the Mediterranean diet score, something like that. And this study referred here showed that the hazard ratios was like 15 to 21% reduced risk of cardiovascular disease simply by eating a healthy dietary pattern of some sort of persuasion. So whether that was the healthy eating index, the healthful plant-based diet index, the alternate Mediterranean diet score, things like that. So there were all, what's really nice about that is that there's no one specific diet that is going to get you to win in terms of cardiometabolic risk reduction or liver fat reduction. There is a variety of options out there, which I think is really nice. It's not black and white. There are no strict rules about what you can and can't ever eat. And it seems to be independent of body weight that these dietary patterns make their effect on cardiometabolic risk reduction. But how do we achieve these dietary patterns? So I'm going to talk very briefly about, firstly, removing barriers to healthy behaviours, just one aspect of that, and then very briefly on nutrition education interventions. So very briefly, one of the barriers to healthy behaviours is weight stigma. Now, I know it doesn't sound very nutritional, but in the context of weight management programs and nutritional interventions for weight management and cardiometabolic risk reduction, weight stigma and weight bias and the internalization of those negative attitudes towards people of a higher body weight are really important, and they themselves are barriers to healthful behaviours. So this is a mind map that I drew up with the late Helen O'Connor some years back, which led to the development of the Everybody study, which I'll show on the next slide. And what you can see are some of the interrelationships between psychological risk factors, such as weight stigma and weight bias internalization, with some of those dietary behaviours that the individual following them sort of, they hope that fad diets and so will lead to weight loss and things like that, but they don't tend to do that. So this mind map in itself could take a whole hour's talk to work through, but suffice to say that those who feel those negative thoughts and those biases against those with high body weight, conscious or subconscious or whatever, and whether this person has high body weight or not, they can still have significant negative health impacts. And so to target triggers for binge eating is only one potential aspect of this whole scene of weight management. If one does not treat the weight bias internalization at the same time, there's a strong risk that whatever you do, whatever you achieve in terms of weight management will not stick in the long term. And this is where the Everybody Study comes in. So that's our little logo there, Everybody Study. And very briefly, this study pitched traditional CBT for weight loss, so things like mindful eating, managing hunger and cravings, against CBT for weight stigma and body image dissatisfaction in young women with obesity. So both groups received the same nutrition education program, which is based on calorie-reduced, low GI, moderate protein diet, and tips around snacking and that sort of things. And I will have to leave it there. I say we've measured a raft of psychological outcomes, but this is the work of my wonderful PhD student, Isabel Young, and I'm not going to spoil her big reveal, but suffice to say that weight stigma is a big challenge and a big baddie when it comes to health and wellbeing for many people, both those with and without obesity. So stay tuned for, the last thing I wanted to talk about was nutrition education interventions, and that's what the top bit of this slide is about. So the My Heartmate study was looking at a gamified smartphone app for patients enrolling in cardiac rehabilitation and whether or not that changed their dietary patterns. So stay tuned for that. We're writing up the results for that right now, and I can't talk more about it, partly because I have no time, but partly because I'm not allowed to just yet. But also stay tuned for the Everybody results as well, and more work in the omega-3 space. So I'm aware I spoke over time, though. Sorry about that. But thank you very much for the opportunity to speak today.
Thank you, Helen.
Thanks.
All right, so we'd just like to open it up. Are there any questions online or in the room?
Hi, Helen. Really nice talk. I was just curious, in your literature review, given that vegan and vegetarian diets are typically low in the long chain omega-3s, did any studies look at those populations and their presence of fatty liver?
Great question. Thank you so much for that. So the interesting thing about vegetarian and vegan type diets is that a lot of the time, if you look at omega-3 index, they're not necessarily deficient in omega-3, which is really interesting. And I think what happens there is there's an upregulation of conversion of those precursor fatty acids to EPA and DHA in people who follow a vegetarian or vegan diet. They didn't look at those populations specifically. And what we also haven't seen yet is a sort of explosion in the research from like algal omega-3 as opposed to fish or marine derived omega-3. And that I think is a research field waiting to happen, because not everyone, so there's, I guess, the sustainability issue of harvesting fish simply to provide us with omega-3. There's sort of ethical issues around that. And also people who don't want to consume animal products. So it's a research space that probably needs filling. So feel free to do that. I'd love to.
Lauren's nodding her head.
Awesome.
Someone just asked if she understands correctly, there are no negative effects either.
Yeah, so the I guess adverse effects you would have from omega-3 supplementation are things like a fishy aftertaste if you've got ones that you burp up, which some people seem to find they do. And there was talk about it having an effect on blood thinning. However, it's not been commonly reported in these studies at all. In fact, I haven't seen it reported at all. I just figured it must be somewhere, because that was some of the, I guess, risks that people talk about when they talk about omega-3 supplementation. But it seems that there are no, I guess, significant negative effects. I must admit, I have taken fish oil sometimes and I've never burped it up, but I don't know if it's just newer preparations seem to have less of that effect than the older versions.
We have another question online asking if you would like to comment on whether you are planning older women who have a high sensitivity to obesity or related cardiovascular disease.
Oh, Anastasia, thank you for the question. I'm happy to research anyone in terms of omega-3 stuff, but I think you're right there to say that there are specific populations that may have particular benefit from something like this. So I haven't got a study in the works on older women with a particularly high sensitivity to obesity-related cardiovascular disease, but it's a really great, I'll take that as a comment. Thank you for that. Any
other questions from the room, and then we'll move on? Nope. Well, congratulations, Helen. Really great work. And thank you so much for taking the time to share that with us today.
Thank you so much, Mon.
I'm sure Helen would be happy to take any emails or any further correspondence on it.
Thank you. Absolutely.
All right. So now I have joining me today is Dr. Angelo Sabag. And Dr. Angelo is a researcher from Western Sydney University. He's currently a postdoc who works in the area of exercise, high intensity functional training, PCOS, also a big systematic literature review meta-analysis guru. And so I'll let Angelo come and present his talk and see that. All right, so Angelo's talk is why less is sometimes more, low volume, high intensity interval training for cardiometabolic health.
Okay, so thanks for the warm introduction, Monique. Yeah, so I think that Helen's talk was so great, and the benefit is that we both had the same PhD supervisor, so you'll see a lot of the same themes coming through both of our presentations, and she's covered a lot of the groundwork for me. So I will only touch briefly on the pathophys before moving into the actual intervention, which is like low volume, high intensity interval training, and then I'll also talk a little bit about what it is that we're going to do in the future. So really brief rundown. During obesity states, so chronic excess energy intake, adipocytes become hyperplasic and they hypertrophy, which means that they enlarge and they multiply, and this causes vascular stress. So these adipocytes can't get enough nutrients, and then they release cytokines. These cytokines then travel to the liver, causing insulin resistance or contributing to insulin resistance, which then has a feedback loop, which means that you have now more fatty acids circulating around. Your liver then loses its ability to process these fatty acids and repackage them and use them as energy. So it's just, as you can see, not an ideal situation, and one that hopefully with exercise, we might be able to improve. So what do? We wanted to see whether or not exercise in and of itself was an effective intervention for improving visceral fat, which Helen so wonderfully covered. We ran this systematic review in 2017, and we looked at different kinds of exercise, so aerobic exercise, which is your typical running, jogging, cycling, progressive resistance training, which involves more traditional like gym equipment. So you could say like barbell work, chest press machines, that kind of exercise. And then we did a combination of aerobic and resistance training. All in all, we found that aerobic exercise was the most effective for reducing visceral fat. And this was not primarily, but this is largely contributed to the large number of studies available. If you look at the progressive resistance training and the combined training, you find that there aren't many studies, so it might be underpowered. And if it was better powered, you might see a significant effect, but we don't know. And now also the similar results can be found when you look at the liver fat. We combined all types of exercise and we saw whether or not exercise was effective for improving liver fat, and it was just non-significant. But again, that's probably because it was underpowered. So what did we want to do? Well, we ran a systematic review. I've done too many of those. That's why I'm repeating the word. We ran a randomized control trial where we looked at variations of aerobic exercise because we had just previously shown that it was effective. And so what did we do? We had 3 groups. One was a high intensity interval training intervention. The other was a moderate intensity continuous training intervention. And the third group was a placebo. Now, these 3 groups all had unique attributes. So for example, the moderate intensity continuous training was designed to replicate the current physical activity guidelines. The high intensity interval training group was designed to be an answer for those who are potentially time poor, can't exercise. So they weren't energy matched, which means that the moderate intensity continuous training group was burning a lot more energy throughout the exercise sessions. And then finally, the placebo group, we devised this intervention so that you can control for attention and other factors which may contribute to effects often seen in clinical trials. So basically the placebo, they would come in once every 2 weeks and just do like slight stretching. Now these exercises were designed not to elicit any improvements, rather they were just to control for those confounders. The really interesting thing here was that our high intensity interval training group, which involved as little as 4 minutes of high intensity interval training 3 times per week for 12 weeks, led to significant reductions in liver fat. And as you can see from, or as you saw rather from Helen's presentation, liver fat is perhaps the metabolic presentation or manifestation of metabolic syndrome. Sorry, the hepatic manifestation of metabolic syndrome. That's a mouthful, but yeah. And then what we wanted to see as well was, granted, it's a very low sample size, so it's limited this analysis, but we want to see how much or what is contributing to this change in liver fat. And as you can see in block 1, you'll find that your baseline ALT, age, and sex will contribute roughly around 27%. When you include change in weight, LDL, triglycerides, and ALT, that improves all the way up to around 61%. And then if you add change in cardiorespiratory fitness, which is a primary which is a primary outcome that can be modulated through exercise, you find that that prediction value increases to almost 70%. So that was a pretty cool finding. And so that was just basically covering glycemia and the relation between liver fat. But we also have done a range of systematic reviews on other cardiometabolic outcomes. So we've looked at arterial stiffness with high intensity interval training. We've looked at body fat percentage and cardiorespiratory fitness, as well as liver fat. And basically the message has just been consistent in that high intensity interval training, despite often being requiring less time and less energy, often elicits similar or sometimes greater improvements in cardiometabolic risk factors. So we summarize this literature nicely, if I don't say so myself, in this review published in Journal of Physiology. We looked at the various effects of low volume HIIT. Now, low volume HIIT is different to just normal HIIT, and I'll get into the nomenclature in a second. But basically, HIIT more broadly is defined by brief bouts of high intensity exercise interspersed with active or passive rest periods. So what does that look like in actual practice? You'll find we can categorize high intensity interval training to 3 different groups, being low volume high intensity interval training, high volume high intensity interval training, and sprint interval training. Now, important to note that all of these kinds of training are aerobic based, meaning that you do them on a treadmill, you do cycling, swimming, or some aerobic based intervention. The intensity typically varies between 80 to 100% VO2 max or equivalent for both low and high volume, high intensity interval training, with the difference between the two just being the total amount of work undertaken. So after, if you combine all the high intensity intervals or high intensity bouts throughout that session, if it is less than 15 minutes, then we classify it as low volume HIIT. If it's greater than 15 minutes, then or equal to, then that's high volume HIIT. Now, sprint interval training is similar to low volume high intensity interval training, with the difference being that instead of working at 80 to 100% VO2 max, you're working super maximally. So what that looks like in practice is basically a person is exercising as hard as they can for up to 30 seconds. Now, if anyone's done a 200-meter sprint in the last 5 years, you might remember that it is hard to finish at 100%. That's because you're pushing around 25 seconds, depending on how fast you are by the time you get to the end of the race. Now, imagine repeating that 4 to 9 times in one session, and it can be really arduous. So that's why sprint interval training is typically not incorporated in clinical practice, but there are some data coming out which show that it can be incorporated if you reduce the interval duration from, let's say, 30 seconds down to 6 to 12. But that's not what I'm talking about today. That's just a side note. And so a typical high volume HIIT session would look like 4 minutes of, you could say, a warm up. Then they do the active bout, which is 4 minutes, and they repeat that for a subsequent. So you have a total of 4x4 intervals at 80 to 100% VO2 max. Now, the difference with, if you count at 16 minutes of high intensity training there, now low volume training, there are 2 main kinds of low volume high intensity interval training. The first being that which is not push, but like it was investigated by Martin Gabala and Jonathan Little. Monique actually did her PhD with Jonathan Little, and this approach, which is the one I like, although I implemented the bottom one in my study, I actually like the 10x1 better. And what it involves is alternating between 1 minute on, 1 minute off for 10 rounds. And by the time you finish, you've accumulated 10 minutes of high intensity exercise. And then that's your session done. Now, what we did was we did 5-minute warm up, 4 minute on, and then 5 minutes recovery. And that was the session. Now, both of these kinds of interventions can elicit improvements, but people are often asking, well, you're working with people with diabetes, chronic diseases. Is it safe? Well, in 2018, there was a systematic review that was published, and they looked at this specific question, and they basically they pulled all the available evidence on high intensity interval training undertaken in a cardiac rehab setting. And bear in mind that this setting is perhaps those who are most at risk of having a cardiovascular event, more so than someone who has, for example, type 2 diabetes, but no subsequent or history of ischemic event. If you look at the data, you find that of 17,000 training sessions, which involve almost 12,000 training hours, there was only one major cardiovascular event, which is quite safe when compared to other interventions. And there were similar findings for both the high intensity interval training and the moderate intensity continuous training group. So these is, apart from my study, which I already covered, there's another study out from, which was published in 2016. This is by Jeff Coombs' group and Shelley Keating, and this is led by Joyce Ramos. I think she's at Flinders at the moment. They looked at a very similar study to us. Instead, they looked at both high volume and low volume. Again, they found similar improvements across both. So we're wondering, like, what is the mechanism? How are these things improving? And basically, if you're going to summarize the effects of high intensity interval training, this slide, which was published, which is from the published study in Journal of Physiology, talks about how it can improve VO2 max. This is one of the primary mechanisms of improving cardiometabolic risk factors, but there are also peripheral factors going on there with like improvements in glycogen depletion and resynthesis, which increases insulin sensitivity acutely, as well as more chronic changes in fat oxidation and the ability of your mitochondria to oxidize fat and use them as energy. So here's a slide on some of the potential mechanisms. During obesity, you have high levels of circulating free fatty acids. These free fatty acids are then transported into the cell. Your mitochondria then tries to process these, but because you have, say, metabolic dysfunction, these mitochondria, either there's few of them or the ones that you do have, they don't operate as best they could. And so what happens is you start to get an accumulation of these free fatty acid byproducts, which is like diacylglycerol and ceramides, and that causes a sustained activation on protein kinase C, which leads to a whole range of downstream pathways and eventually inhibits the translocation of GLUT4 to the membrane. And on this slide, you can see how exercise improves these different mechanisms. You can see that it improves the circulating levels of free fatty acid, as well as improving mitochondrial oxidative capacity and the capacity of the cell to store glycogen, as well as translocate GLUT4 to the membrane. So we published this and we got a lot of media attention. Some of them, you're always happy to get media attention, but some of them I read the title and I just couldn't believe what they were writing. I was like, did you guys read the study? Or, but anyway, it was welcome regardless. It got a lot of views and yeah, so it was one of those things where, yeah, like all researchers, you're happy to receive the attention, but you're always treading a fine line with being, I don't want to say honest, but yeah, you'll find that can be a little bit clickbaity. So where to next? Well, we're currently looking at high intensity functional training for cardiometabolic health in women with polycystic ovary syndrome. So around 1 in 5 women have polycystic ovary syndrome, and it's a combination of hyperandrogenism, which can manifest with polycystic ovaries, menstrual dysfunction, and is often associated with insulin resistance and obesity. And it's for this reason, which I thought, there's a link there. Almost 1 in 2 women with PCOS go on to develop type 2 diabetes. So what if we take a step back and target this population who seem to be or have high levels of physical inactivity and barriers to exercise? And I thought, well, are there any mechanisms or pathways that we can address? And the insulin resistant one seems to be effective with high intensity exercise. And we've shown that in more metabolically severe cases. So the logic was there, but let's just take a step back and also define what we mean by high intensity functional training and how it differs to high intensity interval training to see whether or not this actually might be suitable for this population. High intensity functional training, by the definition, is basically a type of exercise that involves combining both aerobic and resistant training modalities in the one session, alternating between exercise and exercise. and it's done at a high intensity. So an RPE of 7 to 8 or out of 10. So that's basically 70, 80% of your max. And that's kind of the intensity you're working at throughout the session. Now, we are doing this in combination with F45. We're not receiving any money from them, but they are offering their facilities. And basically, the participants will be training 3 times a week at F45, or they'll be doing another intervention, which is basically the physical activity guidelines. That's 150 minutes of moderate intensity continuous training per week. That's aerobic, plus 2 sessions of resistance training versus a weightless control. The intervention goes for 12 weeks. And our target population is women with PCOS who are physically inactive and have a BMI of greater than 25, which classifies them as being overweight. Now, the outcomes we're looking at are lipid profile biochemistry, cytokines, anthropometric data. So we're looking at DEXA to look at bone mineral density, as well as body fat percentage, arterial stiffness, insulin sensitivity, muscle strength and endurance, and cardiorespiratory fitness. Based off this work and work that we've previously done, I'm assisting now with the International 2022 PCOS guidelines, as well as leading the Exercise and Sports Science position statement on exercise for PCOS. So these resources will be available at end of 2022 or early 2023 for accredited exercise physiologists working with women with PCOS. And also I'm assisting Dr. Shirley Keating on the non-alcoholic fatty liver disease position statement from ESSA on exercise for its management. So if you have any questions, feel free to ask them. Below are my contact details. And yeah, thanks for the time.
Thank you. How good was that off timing?
I know. I'll just.
You can stay up here because you're talking to me now. All right. Thank you very much, Angelo, for your talk. We will open up for questions. Anyone in the audience? I guess I can break the ice as one. So we know that there are so many different protocols for high intensity interval training. Does the more time efficient ones necessarily mean people will do them? Like I know it's purported that, less people are time poor, but is there any evidence in the literature that the shorter ones people will stick to more?
That's a good question. And briefly, there was one study that was done by Mary Jung in UBC as well, and they looked at basically 2 groups. One group had been given high intensity interval training, the other was given moderate intensity continuous training. They finished the intervention, but then they followed them for a year and they looked at, well, who was doing the most exercise and what kind of exercise were they doing? And they found that those who were doing HIIT in the intervention went on and still did HIIT after the intervention had finished, but they also supplemented it with moderate intensity continuous training. Whereas those who just did moderate intensity continuous training, they just did that. So it goes to show that if a person can maybe learn how to do a different kind of exercise, they can build up that self-efficacy, it's likely that they can continue it in the future. Whether or not you can actually find the time to do it, there are a lot of other lifestyle factors that might come into play. So I think the biggest thing that low volume HIIT can give someone is just a baseline to familiarize themselves with exercise, because it is intense, but it's brief. And so you can finish your session quickly. You might reach a ceiling effect as to what kind of benefits you can elicit. And after that, you do need to increase the volume or the intensity or another exercise prescription parameter to continue seeing improvements. But I do think it's a good entryway. Now, is there evidence to support that in the literature? It's limited at the moment.
Yeah, it's just interesting when you're trying to decide which HIIT protocol to use.
The 10x1 is a great one. I do that one myself in my own training, and I think it's excellent in terms of like load that you're incurring on someone. If you're using like RPE, something that can be progressively overloaded just without having to monitor anything. So it is. I like the 10x1 Jonathan Little approach, but yeah, I guess it's up to the individual.
All right, I got another question online for Angelo, and this is for the audience. For your latest high intensity functional training trial, is there a comparison group for HIIT as well? So you were doing a high intensity functional group and just a normal cardio HIIT group? Yeah, no,
look, the high intensity functional training group is different to HIIT. It involves the resistance training components as well as just like high intensity exercise. So there is no high intensity interval training group in that per se. There have been studies that have already been published in this field, and that's by Dr. Rhiannon Patton from Victoria University, and they looked at moderate intensity continuous training versus HIIT, and they found similar improvements. In fact, there was some outcomes that have more heavily favored the HIIT intervention. But yeah.
Do you think the added resistance exercise might take away some of the benefits of HIIT?
I don't know. There are talk of being competing mechanisms. So like the mTOR pathway interfering with the AMPK pathway, which is, so mTOR being a resistance training pathway that elicits muscular hypertrophy, and then AMPK, which elicits like mitochondrial adaptations, which improve cardiac function and oxidative capacity. So there is a little bit of talk on that, but I did a review in 2018 where we kind of looked at that, and it was that we couldn't find a conclusive answer. And in fact, you can still improve, for example, resistance training adaptations if you add aerobic training, but whether the opposite is true, we don't know yet.
And they were asking about arterial stiffness, which might be where you're measuring that, so that would be interesting.
Yeah.
For HIIT training, what environments are they typically conducted in? Are they free living or gym studies?
Well, look, firstly, there's a really big misconception out there about what high intensity interval training is, and everyone is advertising HIIT, but there's not necessarily HIIT in the strict sense of how we define it in the literature. So if someone's doing battle ropes and throwing tires and stuff like that, that's not HIIT. That's more of what I'm doing in this study. We are like high intensity functional training. Again, you can argue whether or not it's functional or not. That's another conversation for another day. But there are other terms which are like high intensity multimodal training, and they're typically those that I've used. But that's a really important question, because when you look at the systematic review, which show that high intensity interval training is safe, it's done in cardiac rehab settings, which are supervised by clinicians who are highly skilled. Now, to say and extrapolate that into the general population and ask, well, can they do the same if they have underlying risk factors which they might not be aware of? We don't know. But again, it's free living studies that have involved HIIT interventions typically show low adverse events. So it does seem to be feasible. Whether or not you can completely conduct it in a just a gym setting. For example, there was a study by Sophie Cassidy in the UK. She did that. She basically gave someone high intensity interval training, or a group of people high intensity interval training. They went off into the gym, they did it for 12 weeks, and then it was safe, and they improved liver fat as well as glycemic control. And that was my question on the supervision. No, look, I feel like once you build up self-efficacy and you've taught the participant or the patient or whoever it is you're dealing with how to improve or how to undertake this exercise safely, how to monitor for symptoms of adverse events, so like dyspnea, so being out of breath, tightness of chest, dizziness. Once you can control or increase the patient's autonomy and self-managing those symptoms or identifying them, then it should be fine.
Yeah, so that was just for the audience that was asking whether HIIT needs to be undertaken under supervision. And I guess that comes from the work from Mary Jung et al., where they did a 2-week counselling session, in-lab session, and then the patients went away for the year. So that is that question. Any other from the audience? Mike?
Yeah. So I've got one online. Can I interrupt?
Yes, please, Helen.
I was just wondering, Angelo, if you don't have an exercise bike or a treadmill available to you, can you do it? Can you do HIIT training outside?
Yeah.
How would you go about doing that?
You have legs. If you have legs.
I do have legs.
Yeah, so you can run and you can do HIIT like that. So for example, people think HIIT's new. It's not new. Back in the day, and if anyone has done, a PE class and they remember their PE teacher telling them, you run from one lamppost to 2 lampposts and then you walk the other 2 lampposts. That's basically high intensity interval training. So you can do it like that outside. If you got a bike, you can do it with the bike, similar. It's just basically alternating between, I say brief in quotations because it's not necessarily brief. It can be up to 4 minutes, but shorter periods of high intensity exercise around 8 to 10 out of 10 in terms of intensity, with recovery periods. And those recovery periods can be either passive, so you're doing nothing, or active, where you're walking lightly.
I guess that's that thing. It's 8 to 10 out of 10, not. I was going to ask about then sprint interval training. How do you know if you're doing sprint interval training or high intensity interval training? But I guess that RPE becomes really important.
Yeah, if you know if you're doing sprint interval training because you do it for more than 15 seconds.
Fair enough. Thanks, Angelo.
No worries. Yeah, this is a really good one. So
Can you repeat the question?
So Matthew Hollings, hey Matt, good to see you in a nice research group and doing some good work there. Matt wants to know whether or not maximal test at baseline is necessary for safety or prescription, particularly in higher risk groups. There are different methods for testing for doing cardiorespiratory fitness assessments at baseline. You can take them to volitional fatigue, or you can take them to ischemic threshold or just below. So there are a few considerations that you have to consider. If you're taking if you're taking a population who is like high risk for CVD and they have they're on beta blockers, they might have a lower heart rate, and so if they change their prescription and you base their intensity off a heart rate, then you might have a problem there because their ischemic threshold, for example, might be higher than what it would appear. That being said, typically, and you'll find this in the literature, you can take people further than you think. They're often, you just have to be considerate of the absolute contraindications to exercise. And I think that goes across the board, including in higher risk populations. So if you're looking out for those, then yeah, I don't see why not. And again, I'm not talking about those absolute contraindications to exercise. I'm just talking about those contraindications to proceeding with exercise.
If you're doing a study in type 2 diabetes, would you 12 lead ECG them before you?
Yeah, we did that. So we in our study, which we did for my PhD, we hooked people up to an ECG and we took them to max or volitional fatigue, and yeah, it was safe. We didn't have any ischemic events. Again, I was saying in the presentation, like you often, type 2 diabetes is associated with CVD, and there's a direct relation there, but it doesn't mean that people with type 2 diabetes will have, coronary artery disease or something else that might directly impact their exercise capacity.
Yeah, and I mean, we 12 lead ECG'd all ours and we still had a heart attack in our trial.
Did you?
Yeah.
Wow, was that in HIT?
Yeah.
Oh.
Non-fatal. So.
Yeah. Nobody heard that.
I'm just saying, it's definitely a risk that you can't always mitigate.
Was that during the cardiorespiratory fitness assessment, or was it during
9 weeks into training?
9 weeks into training.
1 out of 80. So.
Any change in medication?
Yep.
And were they exercise naive prior to the beginning? So like, were they inactive when they joined?
Yes, all of them were.
Interesting.
Yeah. Great, thanks everyone for all your questions. So I just want to end by thanking everyone for joining us today, both online and in person. Thank you, everybody.